Do you struggle with PCOS? Hi everyone, I'm Dr. Emma Mary. As a fertility doctor, I want to spend some time today discussing PCOS. Before we get started, just a heads up, this is going to be a fairly short video. I first want to express my deepest gratitude for all the support you've shown this channel as it continues to grow. Please remember to hit that like button, leave a comment, and subscribe so we can keep producing content that truly speaks to you. Also, if you find this video helpful, don't forget to check out my first book, The Fertility Formula, where I go into far more depth about your fertility journey and the steps you can take to improve it. So, PCOS stands for Polycystic Ovarian Syndrome. Because it's classified as a syndrome, that means it's really a cluster of different signs and symptoms that together define a particular condition. Most fertility doctors will tell you they absolutely dislike the name PCOS, and I'm right there with them. But at the end of the day, it's the name we have. When we're talking about a PCOS diagnosis, it's typically made using what's called the Rotterdam criteria. That means you need to have 2 out of the following 3 findings. Number 1, irregular or completely absent periods. So this is essentially a thorough menstrual history telling us whether you're experiencing normal, regular cycles or not. Number 2 is either clinical or laboratory evidence of high androgen levels. Androgens are often referred to as male hormones. I'll explain why this matters shortly, but basically this could show up in blood work as elevated testosterone or DHEA, or it could appear as excess hair growth on the body or face, acne, or even male pattern baldness. All of those count as visible clinical signs of high androgens. Then the third finding is the presence of polycystic ovaries on an ultrasound. And here's an image showing what that looks like. When we examine the ovaries, each follicle appears as a small black circle. Remember, a follicle is the structure inside which an egg develops. Well, in PCOS, you actually have more eggs than the average woman. That's one of the core features of this condition. But here's what happens. These follicles become stuck at a very early stage of growth. They don't mature and release an egg like they should. So instead, you see a large number of small follicles. This leads to a high ovarian volume and a very high antral follicle count. There's a classic appearance of the ovary in more advanced PCOS, where all the follicles get pushed to the outer edge. Picture it like a necklace of black pearls. While the inner part of the ovary looks more dense and solid because it's busy producing those androgens we talked about. So this is actually a very complex condition when you really think it through. It involves metabolic issues, hormone imbalances, and it directly interferes with your ability to conceive. What actually causes PCOS? And how can you tell if you have it? There's a whole generation of women who were never diagnosed with PCOS, even though they showed signs from an early age. And honestly, I have to say that this has been a massive disservice to them. Maybe you went to your doctor as a teenager because you had acne or irregular cycles, and you were simply put on birth control pills. Now, I don't have anything against the pill itself, but I do have a real problem with prescribing it without explaining to patients what we think is going on, why the pill might help temporarily, or what they'll need to do about this in the future for their long-term health. Because a condition like PCOS can have lasting effects on your overall health. These women eventually stop the pill and suddenly find themselves dealing with irregular cycles again, or worsening acne. There's even a group of people blaming the pill entirely, calling it post-birth control pill syndrome, when in reality, what they're dealing with is undiagnosed PCOS. Now that the pill is no longer masking their natural hormone levels, they can finally see what's truly happening inside their bodies, and their hormones are out of balance. There are real issues with how their brain and ovaries are communicating. And now all of that is becoming obvious. Unfortunately, it's coming to light later than we would hope. We miss the chance to intervene earlier, to learn about our own bodies, to understand our condition, or to reduce our future health risks. So I completely understand why this creates extra worry and confusion, because we're only figuring it out later in life. But that's okay. And I want you to know that you can always take action, starting right where you are. So how do you really know if you have PCOS, and what's the root cause? There's a very strong genetic component. A big part of understanding this is knowing that you lose eggs every single month, no matter what. You're born with a fixed number of eggs. Each month, a group of those eggs is pulled from that ovarian reserve. The brain releases FSH, follicle-stimulating hormone, which encourages one egg to grow. As that egg develops, it produces estrogen. Estrogen signals back to the brain, hey, we're doing fine here, and FSH levels drop. Once estrogen gets high enough, the brain releases a surge of LH. That LH surge allows the follicle to rupture and release the egg. Then the follicle reorganizes into something called the corpus luteum, which starts making progesterone. The brain continues sending out small pulses of LH. If you don't become pregnant, that corpus luteum dies off, progesterone levels fall, you get your period, and the whole cycle repeats in a nice, regular rhythm. But with PCOS, there's a major genetic piece. Part of the problem is that you were simply born with a higher number of eggs. This likely has to do with something your mother experienced while she was pregnant with you. Maybe a certain risk factor she had. But essentially, if you have more eggs leaving the ovarian reserve each month, you're going to be predisposed to a kind of miscommunication between your brain and your ovaries. Even in all those months before you ever ovulated or went through puberty, you were still losing eggs. Here's a key connection. When you have more eggs in the reserve, more eggs come out each month. And when you have fewer eggs, fewer come out. So if I have a high number of eggs for some reason, let's say genetics, mom's health, environment, whatever, then I now have a larger number of eggs exiting the reserve every month. But the brain doesn't know this. It can't see inside the ovary. So the brain just sends out its usual amount of FSH. That FSH signal gets diluted among too many follicles. So imagine one woman with 20 eggs gets a normal FSH signal, while another woman with 40 eggs gets the same normal FSH signal. For the woman with 40 eggs, that signal isn't strong enough to push any single follicle to grow, so they all stay small and stuck. This confuses the brain for several reasons. First, each tiny follicle makes a little bit of estrogen, let's say 1 unit each. If your baseline estrogen should be around 20 units, but you have more follicles, your baseline estrogen might be 40 units. The brain doesn't sense that it needs to send out more FSH, and that's part of the disconnect. Then things get worse from there. The ovary loves making hormones, and it really loves making high levels of estrogen, not just that baseline of 40. It starts shifting toward producing more androgens because the pathway from LH to testosterone becomes preferred. Suddenly, you see more androgens being released. Testosterone causes central weight gain, promotes insulin resistance, and then you get this worsening metabolic picture. What that means is you now have inflammation and insulin resistance, which make the ovary even more resistant to normal signals. It also causes some inflammation in the hypothalamus, so the brain has an even harder time interpreting hormone signals coming from the ovaries. That weight gain from testosterone makes everything worse, because fat cells produce their own type of estrogen. Now your baseline estrogen rises just a little bit more, so the brain feels even less motivated to send out FSH. As you can hear, this is a really complicated disease. So we end up diagnosing it based on those end-stage symptoms or findings: high androgens, menstrual changes, and the ultrasound appearance. And you only need 2 out of 3. But what's really going on underneath is this vicious cycle of miscommunication between the brain and the ovary, plus the metabolic changes that just keep fueling the fire. The approach to managing PCOS can be incredibly frustrating, but the first thing I have to say is that far too many people go undiagnosed. Insulin resistance and those metabolic changes are what really drive a lot of the long-term harm, including a higher risk of miscarriage, reduced egg quality, and more. That's where we have to start. We have to begin by changing our baseline metabolic profile and lowering insulin resistance. That means lifestyle changes and often medication or supplements as well. So think plant-based nutrition, anti-inflammatory foods, healing your gut, a high-fiber diet. We know that fewer animal products, less processed food, fewer refined carbohydrates, less sugar, and less artificial sweetener are all beneficial. We want to pay attention to our body habitus, meaning if you can lose even some weight, that can help lower estrogen levels. Some women with PCOS will start ovulating better almost immediately after losing weight. We can also consider medications. I'm a big fan of inositol. Sometimes metformin or GLP-1s can help improve the inflammatory and insulin-resistant aspects of this condition. And even in the best-case scenarios, where patients are doing absolutely everything right, they still may not ovulate on their own. There's no shame or failure in needing ovulation induction medications. Those include letrozole. I have other videos on this. But essentially, they work by telling the brain to send out more FSH. Letrozole is typically the first-line drug for PCOS because it lowers estrogen levels. Since part of the problem in PCOS is often a higher than normal baseline estrogen, lowering that estrogen allows the brain to sense the difference and send out more FSH. Some patients with PCOS have what we call refractory ovulation, meaning even at the maximum dose of medication, they still won't ovulate. Those patients may need direct FSH, gonadotropins, or might be better suited for IVF. My big plea to you is this. If you have PCOS and you want to become pregnant, start paying attention to lifestyle factors as early as possible. Start tracking your cycle, get complete fertility testing before you go down the road of ovulation induction. That way, if you also have male factor infertility or tubal disease, you don't waste months on ovulation treatments only to find out they were never going to work. But the most important thing is early awareness of what you're putting into your body and taking control of those metabolic factors. Thank you so much for being here. Please ask your PCOS questions in the comments below. I know we always get a ton of them. Thanks, friends.